Hello, my name is Leandro Leite. I'm a dermatologist from Brazil, and today we will present a module on differential diagnosis of generalized pustular psoriasis, GPP. Our learning objectives will be that based on clinical and histopathological features, we can distinguish generalized pustular psoriasis from key differential diagnoses, including infections, AGEP, Sneddon-Wilkinson disease, pemphigus, linear IgA bullous dermatosis, and DIRA, the deficiency of interleukin-1 receptor antagonist. So we will start with infections and primarily bacterial infection. Well, impetigo and bacterial infections represent a major challenge in the differential diagnosis of GPP. This is because both GPP and sometimes skin bacterial infections, when they get spread, disseminated, on both scenarios you will have leukocytosis, fever, and systemic signs of infection. Both conditions can present with these systemic symptoms. So this is very difficult, it's very challenging on the emergency department scenario to not start empirical antibiotic therapy, even though if you have a strong clinical suspicion of GPP, because you will always fear that this patient has an infection, and that's because mostly impetigo patients with disseminated lesions, they will share several both clinical and laboratorial features of GPP. Some clues is the positive cultures. Of course, this is infection, and on GPP you have sterile pustules, and on impetigo usually you start with a localized onset, and of course this is a contagious infection, and sometimes other other members of the family can also have the infection. It can help to think on this hypothesis of impetigo. Here again, we have an eczema patient with an eczema lesion that has a secondary infection with formation of pustules here, and on this case the pustules are infectious, and it's very common that the patient with secondary infection they present with infection, they present with folliculitis, and in these cases the pustules they are follicular. So as we can see here on the dermoscopy, the central hair follicle showing that you have a follicular pustule. On GPP, the pustules are non-follicular. Herpes simplex. Well, this is a very common viral infection, and it rarely mimics GPP, as most herpes infections are localized. Well, but however, in some special scenarios, for example, the Kaposi's varicella-form eruption, particularly on the immune-suppressed patients, you can have a widespread vesical pustular lesions, and they may resemble pustular psoriasis. Well, we should always remember that these lesions are extremely painful, and they have a specific pattern they usually get together, they form groups of vesicles and with a background of erythema, and they lack the classic trend to form lakes of pus that we have on GPP. So here we have an example of Kaposi's verticilliform eruption from literature, and this is one of our patients that had atopic dermatitis and developed a Kaposi verticilliform eruption. On this situation, you can call it eczema herpeticum, and we can see the formation of pustular lesions, and they were disseminated. So yes, it can mimic GPP, but again, on a different scenario. A patient with atopic dermatitis that started cyclosporine and then developed these lesions, these painful lesions. Well, this represents another case of disseminated herpes infection. On this case, on this patient, she had a systemic vasculitis and she started rituximab, and she developed this vesical pustular lesions. They were intensely painful, and they had this polycyclic configuration that is typical of herpetic infections. You don't see the tendency toward the formation of lakes of pus, and in case of uncertainty, you should always perform a biopsy, and the histopathological findings are completely different from herpes infection and GPP. Herpes zoster, well, this is the reactivation of the varicella zoster virus infection, and it presents again with vesical pustular lesions, but they are restricted to dermatome area. And now we are going to start talking about autoimmune diseases and autoinflammatory blistering diseases. And the first disease we bring is psoriasis, plague psoriasis, psoriasis vulgaris. We now understand GPP and plague psoriasis as different diseases, and they can occur together as comorbidities. So when we analyze GPP cohorts, we see that we have GPP patients with GPP alone and GPP patients with GPP associated with psoriasis vulgaris. For clinically understanding this disease, psoriasis vulgaris is a more stable disease. You can see a patient one day, evaluate the severity, start treatment, and then you can evaluate the same patient again to analyze the impact of the treatment weeks later, months later, and that's okay. If you see a GPP patient, the changes occur in a daily basis. If you see a patient one day, he can have only erythema and a few pustules, and the other day you will see disseminated pustules and with also lake of pus formation, and then in the other day you will start the healing phase with scaling and you can have new lesion formations in the same flare again and again and again, and then they follow this cycle of scaling and pustule formation. the point is that when we see a lesion of plaque psoriasis, it's usually a lesion with erythema and scaling, but sometimes plaque psoriasis may, during episodes of intense inflammation, exhibit marked neutrophil chemotaxis leading to pustule formation. But the pustule formation is within the existing plaques. Well, these pustules, they remain confined to the boundaries of the plaque, unlike GPP, where you would have pustules everywhere in the skin of the patient, and that's a key diagnostic direction to differentiate GPP from psoriasis vulgaris with pustules, that you can call it psoriasis with pustules. So psoriasis with pustules is different from generalized pustular psoriasis, and that's a plaque psoriasis with intense inflammation. So we have this patient here, and you can see the pustules inside the plaque, and you can see that the pustules are non-follicular, and you can use that as a difference to differentiate from bacterial infection. And here we put them all together. The bacterial infection with follicular pustule, as we can see here, and then psoriasis with pustules. This is plaque psoriasis with non-follicular pustules, and then we have GPP, disseminated pustules, and also the lakes of pus formation. Sometimes pemphigus vulgaris is an autoimmune blistering disease that has a suprabasal level of cleavage, and so you have only epidermis and the roof of the blister that can easily rupture and lead to the formation of painful erosions. Sometimes you can have the formation of pustular lesions on pemphigus vulgaris, and yes, on this time it can mimic a pustular, a generalized pustular psoriasis. But you have some differences that can easily distinguish between these two diseases. So here you can see the blisters that are very fragile, and then you have oral lesions that are extremely common in pemphigus vulgaris. So oral lesions are many times the first clinical feature, and many times also the main clinical feature. So that's very common, and that usually can help to differentiate between these two diseases. And many times it precedes the skin lesions, first oral and then skin lesions. So also pemphigus vulgaris follows a chronic progressive course, unlike the acute relapsing flare seen in GPP. Pemphigus foliaceus is another acantholytic disease, another blistering disease, but in this case the cleavage occurs at the subcorneal level, so it occurs above the suprabasal level of pemphigus vulgaris. So here you have very fragile blisters, and they are rarely visible. So the most common lesions you see are erosions, and also yes, they can be very painful erosions, and they predominantly affect the seborrheic areas, and the clinical picture is usually dominated by erythematous and scale plaques with erosions covered by crusts. And in this case, the mucosal surfaces are spared, and also, and you can see Nicole's sign is positive here, as it is when in pemphigus vulgaris when both diseases are active, and but rarely it may present with pustules and erythroderma. So this is one of our patients that had pemphigus foliaceus and presented with erythroderma and pustules, as you can see on his tite here. But this is a rare presentation of pemphigus foliaceus. You cannot see. You can see that the pustules here are isolated. They are not dominant on the clinical scenario, and you don't have the trend, the tendency to formation to coalesce into lakes of pus as typically seen on GPP. But yet, when you have this kind of presentation, it can be challenging on making the difference between pemphigus and GPP. Well, linear IgA bullous dermatosis can be a differential diagnosis that mimics GPP. However, it lacks its systemic symptoms, and it has more a subacute onset, unlike GPP and AGEP. They are very acute diseases that occur in flares. So lesions show a predilection for flexural areas, presenting as flaccid pustules on a erythematous base that rupture to form annular crust over the plaques. Well, for the diagnosis is supported by the presence of intercellular IgA deposits within the epidermis on direct immunofluorescence. And now we will talk about the neutrophilic disorders and pustular disorders. And we'll start with probably the most important differential diagnosis of GPP. Acute generalized exanthematous pustulosis, AGEP, is probably the main differential diagnosis of GPP. Classically, traditionally, both both have been regarded as different distinct entities. Classically, AGEP is described as a pustular drug eruption. So it's very important that the medical history, you should ask for recent use of antimicrobials like tetracycline, sulfonamides, and terbinafine, also calcium channel blockers, hydroxychloroquine, carbamazepine, or paracetamol, which is also acetaminophen. So those are the medications that epidemiologically has been more systematically described as triggers for an AGEP induction. It is told that AGEP would have a more acute, abrupt onset, and a shorter duration than GPP. Also, it rarely recur unless you have a re-exposure to the drug, and it usually resolves within 2 weeks after the discontinuation of the offending drug. Um, Probably the most important clue to differentiate AGEP from GPP is on histopathology. Eosinophilic spongiosis, so the presence of eosinophils, vacuolar interface dermatitis, and papillary dermal edema, and dermal eosinophilia. When present, it suggests the suggests the diagnosis of AGEP more than GPP. So, presence of eosinophils in the biopsy is probably the most important clue for differentiate AGEP from GPP. The treatment, of course, relies on the discontinuation of the offending drug, and you can also use drugs to make a reduction of the inflammation, of the systemic inflammation. And usually, these drugs are very similar to the ones we use to treat GPP. What is new about that is that recently they analyzed the genetic profile of both diseases, and they share there is a significant overlap in transcriptomic and histopathologic patterns in both conditions. They were called as IL-36 driven pustulosis, and what they found that they share 177 differentially expressed genes relative to health skin, and they displayed marked differences when they were compared to palmoplantar pustulosis, psoriasis, and other adverse drug reactions. So they compare the transcriptomic patterns between these conditions, and what they found is that they were completely different. But AGEP and GTP, they were almost the same. So probably the best way to understand them now is not as distinct diseases, but as a same condition. Probably what AGEP is GPP, where the trigger is as a drug exposure. And to reinforce that way of thinking, we have recent case reports of patients with AGEP that were successfully treated with espesolimab. So it reinforced that they are the same disease. They share a clinical background, they share clinical features, they share histopathological features, they share now a genetic pattern, and also they can resolve with the same treatment. So probably they are the same disease. Of course, not all the medical societies yet think that way, but it's something that we should bring together if we are now trying to understand better GPP, and we first thought that GPP was a part of psoriasis, and now we understand that GPP is a distinct disease, and we thought that JJEP would be another distinct disease, and now we understand that probably it is not. It is a form of GPP. Well, so finally, what we should mention on this topic is that several triggers for the flares of GPP have been described, such as rapid withdrawal of steroids, corticosteroids, infections, pregnancy, hypocalcemia, menstruation, stress, sun exposure, and finally medications other than steroids. So probably the best understanding of AGEP now is GPP, where the trigger is a drug exposure. So, subcorneal pustular dermatosis or Sneddon-Wilkinson disease. Wow, this condition may mimic GPP, even histologically. So, actually, these two conditions cannot be reliably distinguished on histopathologically alone. However, it usually has a more subacute onset, presenting as an asymptomatic eruption. Uh, uh, the lesions are grouped, flaccid pustules or blisters that could contain both pustular and clear fluid. Well, the disease tends to be less inflammatory and less symptomatic than GPP. So here we have an asymptomatic eruption of grouped pustules that evolve into half pustular and half clear fluid, as we can see here. That's very suggestive of Sneddon-Wilkinson. And the blister, they can coalesce and form annular or serpiginous patterns. And it typically, as we said, has more. They have more a subacute onset and subacute evolution than AGEP and GPP. So, interestingly, if we analyze a patient with Sneddon-Wilkinson, that patient could perfectly fit the diagnostic criteria of ERA span for GPP. So yes, they could be a challenge diagnose to make, but I think there are some clues that we should look for. Well, the first one is the way the patient behave. I mean, the way the disease behave better. For example, if you're looking to a GPP patient, you are usually looking to a ill patient. He's bad. I mean, he's not good. He needs sometimes to go to an emergency and get hospitalized. Sneddon-Wilkinson is a different scenario. The patient is not such a systemic symptomatic profile, and we can see the lesions, they usually have these characteristics that we definitely should look for, is that they evolve into a half pustular and half clear fluid. That's very important. That's a very important clue for diagnosis. And finally, we will talk about the monogenic and autoinflammatory syndromes. Specifically, in this section, we will talk only about DIRA, which is the deficiency of interleukin-1 receptor antagonists. This is a specific genetic disease, while GPP is a broader condition with multiple potential causes. Well, but you can also have a monogenic DPP, but in this case, the mutations are the mutations of loss of function of the antagonist of the receptor of IL-36. On DIRA, the mutations are mutations of loss of function of the antagonist of the receptor of IL-1. And also, you have other genes related to the development of GPP. But yes, both conditions can present with widespread pustule formation on the skin. The difference is that DIRA is characterized by osteomyelitis and periostitis, and those two are not typical features of GPP. Well, it's time to say goodbye, and I hope you had enjoyed it and learned something from this presentation. And I want to say thank you very much if you made it this far. And my thanks also go on behalf of the entire IPC GPP working group.